I hope your interviews were as advertised and not particularly stressful, and that you had time to learn more about the program to help make a good decision. And what we're doing here is Noon Conference, and Cory will obviously introduce everything for you. But I wanted to say that what we call Noon Conference might be what you call Morning Report. And so we forever and ever had time figuring out how to schedule a report in the morning when people are rounding and they're busy, and get people to Noon Conference to have some educational time. And so what we do is we do what would be morning report. So that's patient presentations, challenging cases, diagnostic dilemmas, et cetera, with food at Noon Conference. And so that's what you would be doing today if you were here with us, but we'll do it virtually now. And everything that was in the Noon Conference hour is now what's in the weekly half day Wednesday educational session. So that's where that 4 hours of education went. So same amount of education, just structured slightly differently.
Perfect. Thank you, Jeff. I guess we can go ahead and get started with that. So first, I wanted to welcome all of the applicants today. We are so grateful for y'all taking the time to interview with us. Me and everybody, all the other chiefs and all the APDs reviewed y'all's applications. Y'all are fantastic applicants, and we are so grateful that you all came here. So thank you again. And I want you guys sit back, relax. If you want to engage, you can type, you can unmute yourself and say whatever you want, but please don't feel pressure to do that. What we do, how we structure our Noon Conference is we have 3 discussants who I'm going to walk through the case with, who are going to be kind of our lead people. But if you have any ideas or any points you want to make, feel free to chime in, and they're always greatly appreciated. So I will give right now, I'll let all the discussants introduce themselves, starting with Sarah Haegar.
Hi, everyone. Welcome to your interview day at Colorado. I'm Sarah. I'm an intern in the program, categorical and PSTP, and I will be going into pulmonary care.
Awesome. Devang.
Hey, everyone. I'm Devang. I'm one of the R2s, also categorical. I am going to apply to cardiology.
And Shoaib.
Yes, I'm Shoaib. I'm a third year going into match into pulmonary critical care. Originally from Seattle, Washington, University of Washington. So still has my heart. So all of you from Washington, welcome.
Awesome. Thank you so much, guys. Thank you all again for being here. And so one quick announcement for all the, this is one just all the residents. Anybody that's going to be rotating at UCH until February 1st, make sure to download the My Health Connection app in order to register for the vaccine administration. And all residents at the other sites just kind of get in contact with your respective site chiefs about that. And then welcome applicants. Like I said, we are so excited for all of you to be here. You guys have impressive resumes. Y'all are from all over the country. We are so psyched for y'all to be here. So thank you again for taking the time to be here today. And then I wanted to go over the structure of our conferences that Dr. Connors actually alluded to just a second ago. So before COVID, we were doing in-person conferences, usually led by chiefs, but we would always have guest speakers from fellows, attendings from whatever specialty, and even just general better medicine practices, talking about things like health inequities. And then what we've kind of done is we've had to adapt, and we've been doing daily virtual conferences via Zoom, where we kind of do the exact same format that you guys are going to be seeing today. And then when COVID permits, we do attempt to do small in-person conferences. Obviously with the surge, we have had to get away from that, but when the surge does go down and numbers will allow for it, we'll go back to doing our small in-person conferences. And the thing that we do with all of our videos, we actually record all of our videos and we post these onto, this onto our YouTube channel, which is CUIM, the CUIM channel. If anybody is interested to see kind of the different cases we've done, or if you want to get a recap of this case that we're doing today, feel free to hop on there. And so just to kind of also give everybody a little bit of a taste of Colorado, I wanted to show everybody some pictures that I've just accrued over, actually, I think over the past year. So this is a picture up at Lake Dillon, which is probably about an hour and a half away. That's my son who's shirtless, probably in like 50 degree water. So he obviously has more of the Colorado spirit than I do coming from Alabama. And then this is also a picture from Estes Park. Every winter, the elk actually fall and winter, the elk actually come down and you literally have this incredibly close encounter with the elk. And it's an incredible experience to get to see when you go visit Estes Park. So without further ado, I'm going to hand the screen over to Dr. Gergen, and I will start going through the case. All right. So this patient's chief complaint coming in is going to be fatigue, weakness, and leg swelling. So patient is a 65-year-old female who's coming into the ED because of increasing fatigue, weakness, and lower extremity swelling. So she has noticed progressive weakness and fatigue for about a month, has progressed to the point where she has difficulty with her ADLs. She was treated for pneumonia about 2.5 weeks ago and was also found to have hepatitis and had her simvastatin stopped at that time. Since then, she's had worsening fatigue, weakness, myalgias, fevers, and now dysphagia, only being able to take liquids because of concern for choking. She's also noticed pain in her right hand over her left hand whenever she tries to grip things. And then kind of on the remainder review of symptoms, review of systems, she's got dyspnea with mild exertion, pain and swelling in her legs, cough, arthralgias, myalgias, weakness. And then she's got no abdominal pain, no rashes, no dysuria, no blood in her stool, and no chest pain. So without kind of getting into the past medical history, you know, what other, like, if any, other kind of questions are you interested in her right now in this current history?
You know, whenever I see dyspnea as well as lower extremity swelling, it kind of brings me to whether, you know, it's symmetric on both sides or asymmetric, and start thinking about heart failure versus PE. So I'd want to ask her kind of how long this has been going on. Does she have a history of heart failure or any heart problems? Does she have any like bleeding or clotting disorders? And if one leg is more swollen than the other.
Yeah, great questions. So kind of getting into, like, if you, Sarah, I'm going to push you a little bit. So if you're also like, what are the kind of other questions with symptoms you kind of look for if you're looking for cardiac symptoms, for shortness of breath?
Like paroxysmal nocturnal dyspnea, so being more short of breath at night, and then orthopnea, you know, more short of breath when like lying flat.
Yeah, perfect. That's exactly right. Yeah, so she denies both of those symptoms, denies any orthopnea and denies any PND.
Then I'm thinking, just keeping it broad in terms of this fatigue. I would want to check if she has any kind of evidence of malignancy, so any weight loss with regards to her risk factors. We'll also just tease that out in the social history, I'm sure. And then any night sweats, anything to point us toward atypical infections too.
Yeah, perfect. That's great. Yeah, so that's great question. So she does not have any, she has probably about like a 4-pound weight loss over the past month, but she kind of attributes that because she hasn't been eating much because of this dysphagia. And then she denies any kind of night sweats, but she does have fevers. And she said her husband actually documented she had a fever up to 102. So she does have like objective fevers. And then kind of at least going with that question, kind of in her, kind of with the malignancy, she does have a past medical history of breast cancer DCIS, that's status post lumpectomy, as well as currently being on anastrozole for that.
Yeah, I mean,
breast cancer screening's up to date.
Yeah, the rest of her cancer screening's up to date.
Yeah, the other thing I also kind of think about is what type of medications was she on recently. It's not like she was treated for pneumonia. She may have had like a drug-induced liver injury as well. So just kind of seeing any new medication changes. The other thing that's also worthwhile is to get some travel history, because there are some like local endemic things that can cause lower extremity edema. They can cause some heart failure type symptoms. Those are the big things, but really just kind of getting more information.
Yeah, that's great. So she actually does. So she does say she was treated with levofloxacin. She was hospitalized for this pneumonia for about 3 days and then got discharged. Besides discontinuing the simvastatin and being treated with the levofloxacin for a 7-day course, she doesn't have any other, no other new medications. And Natalie, great question, asking about any chest radiation with this lumpectomy, and she did not have any chest radiation. Natalie, what do you want to say what you're thinking about, or? It's okay if you can't, if you don't have ability to have a mic right now, but she's probably talking about, thinking about if you have any kind of radiation, wherever that area might be exposed to, especially the chest, you can get things like mediastinitis, you can get pericarditis, and you can possibly get like a restricted pericarditis, cardiotoxicity, all those things, whatever. And if it's in the lower abdomen, you got to think about things like colitis or cystitis. So wherever the area they got radiation, you should always keep that in mind as one of that causing an itis in that area of the body. So great, good. So I think that's all great question. I think that's pretty great history on her. So I think let's just keep going on. So with her past medical history, I kind of talked about the DCIS was actually 12 years ago. And otherwise, her only other medical history is hyperlipidemia and migraines. Her surgery, she only had a lumpectomy and a hysterectomy. Family history is only notable for a mom who's got breast cancer and a father with type 2 diabetes. And then socially, she's a never smoker, no recreational drug use. She has occasional ethanol use. And then her meds that she takes, so she's on the anastrozole, as we talked about. She's on Tylenol, a multivitamin, and Mobic PRN. And then kind of going with her travel history, because I know you were kind of wondering about that. I'm wondering about that, Shoaib. So she's born and raised in the U.S. She's never traveled outside of Colorado. She has 0 birds after asking. I'll just go ahead and, because I know somebody's going to put that in the chat for any kind of pulmonary symptoms. And then she worked as a bookkeeper for years.
Any travel to other parts of the U.S. or also incarceration?
Yeah, great question. So no, she's never been incarcerated and has never traveled anywhere else outside the U.S. What are you getting at with that, Devang?
Sorry, I asked that after you wrote no travel outside Colorado, but yeah, like, is she at risk for histoplasmosis or blastomycosis or something? One of these atypical infections.
Yeah, totally. So does she have some kind of like atypical infection that's causing like pulmonary symptoms? Is great. And then you were talking about incarceration. What were you kind of alluding to with that?
Places a risk at TB. Also, somebody just wrote in the chat about HIV. So yeah, IV drug use would also put her at risk for that if she's doing that.
Yeah. Yeah, and actually, Dr. Albert's kind of thinking, what do you guys think about this hand pain with gripping?
I'm not sure. It doesn't really fit in any schema that I'm thinking of. It's odd that it's left pain greater than right. I'm trying to think of what can potentially cause like unilateral hand pain. A lot of times when I think of the pain, it's usually like some sort of radiculopathy or nerve injury that's causing pain, particularly when you're utilizing your muscles. Trying to fit that with all the symptoms, I think we're just missing a couple of key things that we'll hopefully get. It just doesn't really fit with any schema that I can think of at this time.
Yeah, and I think Shoaib, I think you're thinking great things. I think we're classically taught that when we think about like true synovitis, it's actually pain like first thing in the morning when they wake up. But the other thing to think about is if you have so much swelling, and you can't bend your fingers, like and if you guys think about pain is just like a perception of like being stretch fibers being stretching that actually like triggers these pain fibers. And so if you like bend your fingers and like whenever she tries to grip, that could be from like could be from like her having so much swelling in those joints and causing that kind of pain. Just think kind of some things to think about with that. And then
sorry, I was gonna add in here. This is one of those really challenging cases where there's multiple symptoms you can shoot at, right? Like you could make a differential for fatigue or weakness or leg swelling or pain or dysphagia or unilateral hand discomfort. And there's gonna be some overlaps. And then the hard thing is that the number of things that cause all of those is also several. And so I think this is the one where, as opposed to ending up at the end of the day where we start ordering tests for each of them, we're going to have to decide what we're going to chase after. Look for some basic patterns and then try to go after the one that provides us the most specificity, I would assume.
Yeah, great point. Thank you, Dr. Connors. Well, so why don't, before we get to a problem representation, let's do our physical exam and vitals, and then we will hop into that problem representation. So her admission vitals when she came in, so she actually had a heart rate of 120. Blood pressure was 110/55. She had a temperature of 37.6, respiratory rate 22, satting 92% on room air. And her physical exam for the most part, so she didn't look like she was in any kind of acute distress. HGENT had dry mucous membranes. Cardiovascular was tachycardic, but no murmurs, rubs, or gallop, no elevated JVD. Her lung exam showed tachypnea, no accessory muscle use, no wheezes, but bilateral crackles with shallow respirations. Abdominal exam didn't have any distension or tenderness to palpation. And then on her MSK exam, they actually comment of multiple areas of synovitis in the PIP joints and bilateral hands. And is that all you guys want from the physical exam, or is there anything else that you guys would want?
Is there any
The derm exam.
Yeah, so derm exam does not have any rashes. And Dr. Haegar?
That's exactly what I was going to ask about, was any rashes.
No rashes. There weren't any rashes yet documented. And then so they did do a neuro exam as well, and they did notice that she did have 3 out of 5 strength in bilateral proximal muscles, as well as 2 out of 5 strength in the bilateral proximal lower extremity muscles.
Did they say anything about the distal muscle strength?
They said it was normal distally. What are you getting at with that, Sarah?
There are different myopathies and stuff that can affect more proximal muscles than distal muscles.
Yeah. That's great. Do you have kind of a schema you think about with more proximal versus distal muscle weakness?
I don't have a specifically defined schema, but I commonly often think about Lambert-Eaton, some of the dermatomyositis and stuff can also affect more proximal than distal.
Yeah, no, that's great. Honestly, that, I think that's a fantastic point. Or most of the inflammatory myositis are actually going to be more proximal weakness, and the ones that are going to be more distal, the only one that kind of comes to my mind off the top of my head is actually inclusion body myositis. And so usually, for the most part, our inflammatory myositis are going to be more of the proximal muscles. And then Apoorva actually asked about any skin tightening, and that's a great question. And I think Apoorva, I think you're getting at scleroderma. What do you? I don't know if you have a mic and you want to kind of address that real quick, or.
Yeah, I was thinking of, can you hear me?
Yeah, yep.
Yeah, I was thinking of scleroderma because of the multiple different organ systems that are involved, as well as the exam. So crackles could be scleroderma involvement in the lungs, and then it would cause dysphagia as well.
Yeah, no, Apoorva, that's great. I completely agree with that. And yeah, you're thinking, especially with that dysphagia, does she possibly have a CREST syndrome? And this is GI involvement. So great. Hold on, stop that. Nope. Sorry, that was my 6-year-old. So just to keep things moving, Shoaib, do you mind giving a quick one-liner for this patient?
Yeah, sure, I can do that. So this is a 65-year-old remote past medical history of breast cancer, status post lumpectomy, who presents with 1 month of lower extremity edema, as well as dysphagia, hand weakness, with examination notable for volume overload, as well as synovitis.
Perfect. Yeah, and I'd probably put in there with like persistent, I think you put probably the only thing I'd add in there is just the dyspnea I'd put in there as well. So good. So you got this physical exam, you've got your problem representation. What are you guys thinking right now for this patient?
I think like it sounds pretty rheumatic to me. Like that would be kind of toward the top for me.
Perfect. Yeah.
For everything we've already mentioned.
Okay.
Yeah,
Okay.
and I agree with Devang. It sounds like there's multiple systems that are affected. And so when you start thinking about that, you start thinking about some of your systemic autoimmune conditions, such as CREST, for example. I think we still need some more information, such as laboratory information, to see if the kidneys or internal organs are affected, which would be very helpful. The other thing that's really notable is that her JVP is not elevated, although she has evidence of kind of volume, like I'll say volume overload with no extravascular volume overload as opposed to intravascular. So that makes cardiac a little bit less likely, although still possible. But I would just think of anything that causes multiple systems to be impacted. And usually that's rheumatologic more often than not. Could also be some sort of a malignancy causing like autoantibodies as well.
And sorry, I think I may have missed this. Did we check for pitting versus non-pitting edema in the legs?
No, so she did not have, she had like trace pitting edema.
Okay.
Yeah. Great question. So, and I think that's a great starting point for this. And so why don't we go ahead and move on to the labs for that? So you're going to get a CBC and BMP. Is there anything else that you guys would be interested in getting?
Maybe like ESR, CRP.
Okay, ESR, CRP, maybe one or two more, or I'll give you guys 3 more labs total to get.
Turn to ANA and check CK.
Check a CK, ANA, perfect. Yeah, I think that's great. I think that's
one thing I'd also get is a B Nancy peptide. That can also be a little bit helpful to see if there's any intracardiac pathology.
Okay. Yeah, so we've got all those labs, so I'll just go through them with y'all. So for her CBC, her hemoglobin was 13, white count is 19, with 16 of that PMNs. She had a platelets of 448. Her BMP showed a sodium of 131, potassium 4.6, bicarb is 20. And then she had a BUN of 18 and a creatinine of 0.7. And then you guys wanted ESR CRP. Her ESR is 72. CRP is 109, which for the applicants is elevated for us. A normal CRP on ours is about 10 and normal ESR is 20. And then ANA is pending. And then her CK is 5,000. And then her BNP came back at 96, which is normal. All right. So you've got these labs, you've got this history, you've got her presenting symptoms coming in, got her vitals. What do you want to get right now? Apoorva, she did get LFTs, and LFT showed a, I'll just read the pertinent ones. Her albumin is 2.8. AST is 257, and ALT is 213. So guys, y'all got these labs, you've got this history, you got this exam. What would kind of be y'all's next step in this whole process? Like you guys are like, imaging, EKG, knowing some other labs might take a while. So what are you guys going to kind of do in the acute setting to be in the diagnostic realm for this person?
I think ultimately with that CK elevation, with the ESR CRP being high, like I'm certainly pushing more toward the rheumatic side of this with muscle involvement. So eventually, like we need those myositis panels, and then also like there may be a muscle biopsy in our future.
Good. Now, what do you think about like with her presenting symptoms that she's coming in with? Like, do you guys want to, she's coming in with this fatigue, dyspnea, that didn't get better after getting treated from pneumonia, weakness. Is there anything you guys want to do like that you could do kind of while you're, so we'll you're going to get a myositis panel right now, but that's probably going to take a couple days at least to get back. So what do you want to do in the meantime?
We can get her on steroids in the meantime.
Do you want to get any kind of imaging for her at this moment? Kind of to work.
Yeah, we got to image the lungs, and so I would do a CT chest to start off with at least.
Perfect.
Can somebody put this in the chat panel too? I think a CT ILD, more specifically, I think that would be helpful. But that's obviously after we get a chest X-ray and just to see if there's any obvious abnormalities we can see there.
Yeah. So perfect. Yeah. So I'm gonna let Danny hit this guy over to me right now, and so we'll go ahead and get the imaging modalities that you guys asked for. Let me go back. So this is the patient's chest X-ray that she got in admission. And so you're in luck because they actually did get a PA and lateral. And Sarah, I was going to see if you can give me the read on this guy.
Yeah, definitely. So kind of going through just a little bit systematically, like A, B, C, D, E. Her airway looks midline and looks fine there and patent. For bones, I don't see anything. In particular, her cardiac silhouette looks normal, and no like widened mediastinum or anything like that. For her diaphragms, they look equal, not one higher than the other. And look for any effusions. I don't see anything. It looks like crisp costophrenic angles. And then kind of looking at the lung fields, it is kind of difficult to see. You do see like some stuff in kind of like the area of like the right lower lobe. I can't really tell if there's like reticular versus like alveolar infiltrates, but it does look like a little bit fluffy. It's hard to tell though everywhere else if I see any reticular changes. I can't quite tell.
Kurt,
Yeah.
can I add a couple things there?
Yeah. That was a great read, by the way, Sarah. Thank you.
The other things I actually wanted to also look at is for just looking at the size of her esophagus. We can see that here. It's not very large, but that's just something to think about with her dysphagia history. The other thing I would also say, falling into her E, is the beautiful hoop earrings that she has. They're quite remarkable on this X-ray. So that's just something I wanted to add. Yeah.
No, that's great. And I think Sarah just saying that she's got some gouache in that right lower lobe is totally a fair call. And then, whenever I look at a lateral, one of the things that I always look for is the spine sign in these patients, where you see when you're going down the spine, it actually should become more loosened as you go down, and as you go down the spines, and when it seems more opaque in the bottom, more opaque when you go down, makes you more concerned for any kind of infiltrative disease. I actually would love to hear what Dr. Connors and Dr. Alberts think about this, because my one thing is I was wondering if this just didn't have a great penetration on that lateral film to be able to actually see like those lucencies.
Rick, do you want to go first on the X-ray here?
Well, I'm glad you commented on the earrings. That's the first thing I saw. She does have also a lot of dental work that you missed. That is equally unimportant. The left lower lobe, you don't see the diaphragm on the left side. So there's something on the left side. It could be infiltrate, it could be effusion, it could be atelectasis. I don't think it's atelectasis because there's not other signs of that. But she certainly is missing the left medial hemidiaphragm. I don't think I would call anything in the right costophrenic angle. That's a very difficult place to read because of overlapping vascular shadows. But I actually get a sense, if I look further laterally out in the pleural margin, there might be some interstitial infiltrates in that right lower lobe, and possibly left as well. But it's a portable film, and that's screwing up our interpretation. That's particularly screwing up our interpretation on the lateral. First of all, she's not sitting up. It makes you wonder whether she has other kind of weakness and can't sit up. But a portable lateral film is really not worth spending a whole lot of time on unless there's something very obvious. It does look like it's completely hazy. It would be consistent with a pleural effusion, but on the PA, you don't see any substantive pleural effusion. So I think this is all artifact. One vertebral body seems to light up more than others. Can't tell you which one it is, just below the carina. But you don't want to overinterpret a portable lateral. They're really not worth the money.
Yeah, I agree. This more than anything else reminds me why I shouldn't let you go first on these. But yeah, totally agree. You know, when you see, and Sarah, you sort of commented on this a little bit, when you see that left hemidiaphragm, the cuff spring angle is clear, but as soon as you see it right above that air bubble that's in the stomach there's really is, you know, our eyes can pretend we see that thing going across the midline, but there's no actual line there. And so anytime you think you see a spine sign, if you want to pull the lateral view into this, then you have to find it on the other view. You know, you have to say, well, all right, what is that infiltrated? If we want to believe that is a retrocardiac infiltrate that was easiest to see on the lateral, I think that would be the only thing I would add to this.
Yeah. And then when this is kind of her film before.
That's more obvious.
Yeah. And so the read that was on here was slightly increased right lower lobe pneumonia, and then kind of the stable left lower lobe pneumonia, but nothing. Sarah, that was a great read that you picked up on that. So we did get a CT chest on this patient, and this wasn't a high resolution CT, but this was a CTPE actually, because the patient was persistently tachycardic, and this is the lung view of that.
So before Cory calls in someone to read this, I'll just say, because it's got all the stuff. So when you read this, you can say stuff and you'll probably be right. The difference between a CTPE and a high res or ILD CT, it has to do with the intensity of discrete findings. You can see how thick the millimeter cuts are versus how many cuts there are. And so when you have a regular CT, you're going to get cuts every 3 or 5 millimeters. Which means you're not going to miss anything that's bigger than 3 millimeters. But each of those cuts has less resolution. When you get a high res or an ILD CT, they might cut once a centimeter, but you're going to get greater resolution within that cut. And so you can miss nodules and things like that. But what you do see is going to show you the lung architecture better. So that's why you might do that. If you're looking for lung architecture, that's why you might get those ILD CTs.
Great. Thank you, Dr. Connors. And then Dr. Fakri, since you're going to be our budding pulmonologist next year, I wanted to see kind of your thoughts on this CT chest.
Yeah, absolutely. So the way I kind of think about CT chest is I start from the top down, obviously. Look at the airways, look at the vasculature. Can you actually go back to the PA versus the aorta angle? I just want to look at that real quick. The main PA. Okay, all right. So, the things that I see here predominantly, I do see some pretty predominant airways. I wouldn't call them traction bronchiectasis because they're not going all the way out the peripheries, but they're pretty large airways. The other thing you also see is if you go down to the bases, you do see some ground glass opacities down on the right base, as well as a frank consolidation to the left with some air bronchograms. You can see the airways inside, basically an alveolar filling process. You do also see some evidence of air bronchograms on the right base, but more of it's like those ground glass opacities. The other things I looked at for this one too is, again, I looked at esophagus and it seemed like it was normal size. The heart, it's hard to say in this, but it looks grossly normal size as well. And then I looked at that PA versus aorta, and that can kind of give you a rough estimate if there's any elevated PA pressures. And the PA looks smaller than the aorta as well. So that suggests against pulmonary hypertension, but again, you can't tell that on this CT scan. Mostly in the bases, I don't see really anything in the apices as much, and it's predominantly bilateral bases as well, which kind of fits with our chest X-ray findings.
Yeah, great read, Shoaib. Devang or Sarah, anything that you guys kind of noticed on this CT scan when I was running through it that you'd want to point out? Or
I think, yeah, I agree with all that.
Okay, good. So so right now we've gotten a CT chest. I'm sorry, I'll show you what the read on the CT chest said. No PE, but it did comment that there was bilateral. She had a CT at her last hospitalization, and they comment that there's actually increased bilateral low pulmonary consolidations. They say it looks like worsening pneumonia. And it does have new mild bronchial wall thickening that's probably related to infectious process, but differential in consideration is reactive airway disease. And Dr. Albert, I apologize. I was wondering if you had anything else that you'd want to point out on this CT check.
No, go ahead. You're doing fine. There might be some very small bilateral effusions, and I wondered on one cut whether there was a pericardial effusion, but I don't think that, I'm not sure about that.
Okay. So you've got this patient, you've got her objective findings on her physical exam, you've got her subjective findings. What do you want to do for this patient? So you've got a myositis panel cooking right now after what Devang wanted to order. Is there any other like imaging modalities that you'd want to know? Any labs, anything else, or would you want to consult anybody?
Can we get a urinalysis with microscopy? I just looked for like proteinuria. I think that's one thing we forgot.
Yeah, so she did actually get a UA, and it did actually show she had she didn't have frank blood, but she had large amounts of blood, 11 to 13 WBCs. It was leukoesterase positive, it had about 100 of protein, and it had a bunch of like hyaline cast and granular cast in it.
And then just kind of loop back to her dysphagia a little bit. Did we get like a barium swallow or esophagram or anything like that to define whether it's like oropharyngeal dysphagia or esophageal dysphagia?
Yeah, that's great thoughts, Sarah. So there actually was a barium swallow that was done. And what they actually comment on is they get an episode of aspiration with thin liquids, kind of this slightly delayed swallow initiation and moderate residuals in the vallecula and the piriformis sinuses, which that last part is like totally I'm oblivious to, but all the other stuff suggesting that she did have does have some aspiration that was seen on her echo.
And then on examination, another question I have is, does she have anything pointing towards like myasthenia gravis? Like, does it get more weak with activation of muscles?
Yeah, no, that's a great question. So what do you, so what's classically the history you think about for myasthenia gravis?
The way I think about it is particularly increased weakness with prolonged muscle activation is what I think about. I forget exactly the exam maneuver. There's one thing to do with the eyes and one to do with the hand grip as well. So please remind us, Cory.
Well, I can't tell you the exact test that you're thinking of, but the classic history is that they usually will complain about weakness at the end of the day. So they're just like drained by the end of the day. And the other one is they'll complain about double vision, because if you think about it, your eye muscles are the ones that are moving the most, and they'll complain about double vision that usually happens at the end of the day. It's kind of the classic myasthenia gravis story. But usually, like, it's mostly fatigue is like probably the number one complaint that they have, and weakness, which is like probably 80% of what patients come in with. So so you got the CT chest, you've got the swallow study that's showing she's aspirating. Would you want to call any consult services, start any meds, get any other labs, imaging? What would you want to do at this moment? Devang, what are you thinking about? I see you pondering pretty hard over there.
So I'm actually still wondering about those LFT abnormalities, if they were pursued a little bit further with, say, hepatitis viral studies. then perhaps some right upper quadrant ultrasound at least, just to see if there's any steatosis or anything there. And then certainly, like, right now, I'm still leaning more rheumatic, but could certainly be something infectious too. So I would right now want to talk to rheum, just see what their thoughts are on this, or if we should start any empiric therapies at this point.
Yeah, great. No, you brought up a great kind of segue point. So what do you think about her LFTs? What is your thought?
Yeah, I mean, they're just mildly elevated. So certainly, like, I don't think this is this is not something where we're reaching into acute liver failure territory or anything like that. She could have some kind of hepatitis B or C picture potentially. She could have, I don't know what her previous LFTs were like as well. It does look definitely hepatocellular in the pattern rather than obstructive though. So the usual things we think about there.
Yeah, the thing you think about also is, does she have that drug-induced liver injury? One, is this just getting better? Or two, was that actually a drug-induced liver injury, or just the start of something that that we're now seeing?
Yeah, Porter actually put some great comment on there. So what about like this possibly being like a pseudohepatitis? So what do you guys think about, can anything else cause you to have elevated AST, ALT?
Yeah, usually the AST is elevated from muscle breakdown, although the ALT can be elevated as well, but usually more the AST than ALT.
Yeah, totally. And so she did get the workup, right upper quadrant ultrasound was normal. She got she had all her hepatitis serologies checked, and those all came back normal as well, or came back negative. So what they ended up doing, they did end up calling rheumatology, and rheumatology went to see the patient, and here, let me share my screen. So rheumatology ended up seeing the patient, and they noticed that she did have active synovitis as well as these findings on her hands.
Oh, you didn't tell us that.
Yeah, but that would have been cheating.
Yeah, that would have been the diagnosis from the very beginning.
Did any of our discussants, does anybody know what this is?
Yeah, it's mechanics hands, which can be seen with dermatomyositis.
Yeah, and
anti-synthetase.
Yeah, in particular anti-synthetase syndrome. So she actually got diagnosed with anti-synthetase syndrome. She was started on prednisone, 1 mg per kg of dosing. In addition, she was actually treated for an aspiration pneumonia. She got PFTs done that actually showed her to have a restrictive physiology with decreased DLCO, and was seen by pulmonary rheumatology on the outpatient, and was started on mycophenolate with improved for a steroid-sparing agent. And then she actually had her serologies came back that showed this. So she had a negative ANA. Myositis panel was only positive for the anti-J1, but grossly positive, and her scleroderma labs came back negative, and C3, C4 were also normal. And then
you didn't give us the results of her echo. Did she have cardiac involvement with this?
No, she didn't. So that's a great question. So she actually did not have, at least there were no wall motion abnormalities that they picked up, but she did have what you kind of called, she did have like a small pericardial effusion that you did notice. So she got treated with mycophenolate, got treated with steroids, and then 1 month later had this CT scan after initiation of treatment. And Dr. Connors, Dr. Albert, I don't know if either one of y'all mind kind of giving us what you see on this CT chest.
Well, she still has bilateral lower lobe ground glass. It's not a whole lot better. It's maybe a little less consolidated than it was on the previous one, but she still has the same areas of involvement, maybe even progressive. But the ground glass is concerning.
Yeah, I would agree. And I saw that the UCH residents called me out just in case I was going to try to look smart in front of our applicants today, but I already told them this was my area of expertise. So they know that I would be cheating. But yeah, I agree with Rick. You know, I'm buoyed by the fact that the consolidation has gone away. The ground glass is worse. The reticulation in the lower lobes is worse. Her upper lobe infiltrates, she had a little bit of non-dependent things in the upper lobes. Those appear to be better than they were before. But, you know, following imaging in these patients is, I think, less helpful than following pulmonary function, 6-minute walk tests and all the clinical exam maneuvers. And so I probably wouldn't put a ton of stock in this either way, unless it was obviously worse or obviously better.
Perfect. Great. Thank you. Yeah, I didn't know if there was anything that, you know, in the hindsight, like, I think they must have done the right thing actually treating this patient for like an aspiration pneumonia event, or treating this patient actually for pneumonia. And that, like you were saying, like the consolidated part, because she was probably chronically aspirating, and then the consolidated part looks like it improved, but obviously the inflammatory lung changes are still persistent and they're actually progressing. So I just wanted to,
I want to give a shout out to I saw that Sneha pointed this out earlier, that Brady Campbell identified this about 10 minutes into the report. So
I know.
Not
Brady,
not surprising. Not sure what we're going to do with Brady for her third year. We're going to teach her something, but.
So I was going to give a quick talk about anti-synthetase syndrome. So it's actually it's fairly common in those patients who actually develop a pyomyositis or myositis, afflicting about 30 to 45% of these patients. The interesting thing too that I'm always learning about, so anti-synthetase syndrome includes the antibodies that are actually directed at the tRNAs, with the most common being the anti-Jo1. The criteria for actually diagnosing anti-synthetase syndrome does include a positive anti-synthetase antibody, which does include like 10 other antibodies, but they're way less prevalent than the anti-Jo1, plus evidence of myositis, ILD, arthritis, mechanics hands, unexplained fever, Raynaud's phenomenon. The inflammatory myositis in general just classically affect the proximal muscles that we were talking about earlier. And it's usually non-painful unless you have like a necrotizing myositis or polymyalgia rheumatica. And the usual treatment begins with prednisone 1 mg per kg, but if rapidly progressing, you start them on pulse dose steroids with methylpred of 1 gram a day. And these patients actually have refractory disease. You actually can treat them with some of the biggest guns in rheumatology, which is cyclophosphamide, IVIG, or even rituximab. And I wanted to give a shout out to Dr. Connors for where I cited all of this data from. This is actually Dr. Connors' paper in 2010 that was published in Chest Journal, which is one of the bigger journals in Pulm Crit. And this was just, and after reviewing his paper and then looking over kind of expert opinions, it does look like the information in this is actually still relevant to today. So it was has stood the test of time. But thank you again to all of our discussants for this case. I really appreciate all y'all's participation. I want to open it up to y'all if y'all had any other like thoughts about this case or anything that y'all had questions about with this patient.
Hey, Cory, go ahead.
Oh, sorry, go for it.
Oh, Cory, quick question on this leg swelling. Was there any evidence of pulmonary hypertension on the echo, or was the right heart cath done at some point? Did it go away?
Yeah, no, great question. So, so she did not have a heart cath done, and her RBSP couldn't be. It actually said it was normal, so she didn't have any, at least on echo findings, didn't have any evidence of pulmonary hypertension. And I think all of her respiratory symptoms came from pulmonary itself.
Did she have any further imaging to evaluate for malignancy, given that this can be associated with malignancy or recurrence of her breast cancer?
Yeah, great question. So she has, last I saw, she's been following with, she has been following with her oncologist pretty closely. They had just continued her anastrozole. She hasn't had like a repeat PET scan. There are like certain antibodies that are a little bit more associated with malignancy on the myositis panel, which she did not have. Dr. Connors or Dr. Albert, I don't know if y'all want to y'all would know better than I would, but my presumption is that anti-Jo1 is usually not associated with malignancy as much as like certain other antibodies in the myositis panel.
Yeah, that is true. Although they're all possible. And so I agree with Sarah. When I see someone of older age presenting with this, I do a full malignancy workup, including any screening that hasn't been done already. It's about a third if it's going to be cancer associated. A third of the time you'll get your rheumatologic findings first, and then you find the cancer later. A third of the time you'll diagnose them simultaneously. It'll be fairly obvious that there's a cancer and this thing going on. And a third of the time you'll have a person with a known cancer who then develops this as part of their perineoplastic syndrome afterwards. So I think it's certainly on the table for her. And the only I saw two questions here. One is about anti-MDA5 disease. It's really, really interesting phenomena. That's the anti-myositis. It's the ADM, anti-dermatomyositis. Sorry. So anyway, it's free in the acronym. But anyway, that is patients who do not have myositis, but do present with skin findings and interstitial lung disease. And so her mechanics hands make that much less likely, and her CK of 5,000 makes that less likely. So probably not MDA5. And then someone asked type of tRNA synthetase autoantibody in rheumatologic disease. There's not. So people have tried to figure this out if the PL7s, PL12s, KSs, whatever they are, make for different disease. It's not clear that happens. What is clear is that the pathology on your lung biopsy, which we don't always get, but if we do get, determines your outcome. And so these patients can have cryptogenic organizing pneumonia. They can have NSIP. They can even have UIP patterns like you might see in IPF. And that is what determines how well you do with the disease, not necessarily the autoantibody. So good to know. But if you want to try to be predictive about it, usually you have to get lung biopsies, which we don't do in most of these patients because that is also associated with an inflammation of the disease. And so we try to avoid it unless you have to.
Yeah, the only other teaching point I wanted to make on this is, which you guys did a great job about, is, somebody's coming in with persistent pneumonia, even though they were adequately treated. It is feasible that they could have a recurrent pneumonia or an inadequately treated pneumonia. But like taking a step back and instead of doing your quick thinking that this is just diagnosis of recurrence pneumonia, seeing if there is another pulmonary disease that is not being adequately treated. So that was kind of the big thing to get from this for me is that, if things aren't fitting your script and things aren't making sense, take a step back, think about it, and make sure we're addressing all the possible scenarios.
Jeff, which pathology on the lung suggests poor prognosis?
UIP pattern. And it grades out. So there's patients with a COP who do really well, and those are the steroid responsive ones. Yeah. There are fibrotic and cellular NSIPs and UIP, and that's exactly what you'd expect for badness.
On that second CT scan on the right lower lobe, she started to have some interstitial thickening right that was subpleural, very consistent with a UIP pattern developing that she didn't have on the previous CT. Go back down a little bit. Keep going. Keep going. Right now, right at the
very bottom. There are two cuts up or so.
Right at the bottom, there's some radiographic signs that are suggestive of UIP. So she might not do so well.
Yeah, I totally agree. And almost the best case scenario when you see that is going to be a fibrotic NSIP, which is not much better. And we published this that was our review article. There's a second paper looking at the 87 people with different antibodies. And that's what fell out of that paper is it was all about your lung biopsy in terms of how you did.
Yeah, that's exactly what the read was, Dr. Albert, is they actually did say that it is a UIP pattern. So perfect. Well, thank you again to all of our discussants. Applicants, y'all are going to hang on the call, and Dr. Connors will be directing you to the next thing. Thank you.
Yeah, Devang and Sarah and Shoaib and everyone, thank you for doing that case. Really, really appreciate that.
Absolutely. Come to Colorado, guys.
Yeah. Oh, and Shoaib, by the way, Chet Otis on that paper, he's at Pitt, so you can work with him now after. He'll tell you he'll give you the real answers to all that stuff.
Love it. Love it. All right. Thanks, guys.